but this is kind of what we're presenting and what we're putting forward and fitting our plans into. So it's taking a small piece of what Doug had put together and trying to bring it down to manageable bites that we can plan on. So I'm going to quickly walk through these. Basically, at the bottom you have your standards, we have our data sets, and then those integration layers that start to bring data together and present it. So on the data front, there's going to be a number of different pieces that we bring together. Shared registries that will be supported by eHealth Ontario. So Doug mentioned the client registry of the EMPI where we can identify who patients and clients are. That seems like a fairly simple thing. If you take the patients, within KGH, I think the number in their database is somewhere around 125, 250,000. That's a fairly small number, you can manage it. If you look, though, across the province, you're looking at 11.5 million people accessing an electronic health record, because it goes beyond the clients as we start to roll patients in. So being able to identify who the patient's clients are, who the users are, and manage privacy is something we'll largely strive to do at the provincial level, and that's that shared registries that Doug mentioned. Common health assessments are something that isn't at this point in the eHealth Ontario plan, but it's something the ministry's been working on through the Community Care Information Management Group. Our little initiative around Itarai-Cha is actually leading the province in the community area, but there's other work around the OCAN tool for mental health, long-term stay assessments that are already in place. And bringing those together as a piece is another part that we feel as a LHIN will bring into this electronic health record and present to people. Shared clinical data repositories, so Doug mentioned the one supported by eHealth Ontario around labs, regional groups like HDIRS is our diagnostic partner. Hospital Diagnostic Imaging Repository Services is what the acronym stands for. Now, people talk about engineers being geeks and propeller heads. That's an acronym that the radiologists actually came up with. So HDIRS, if you can come up with a better one, you might win the prize for naming the corporation, because it's really not that inspiring. Select Labs, Drugs and Imaging, and then Clinical Document Repository, which Todd's going to speak to a little bit later, but a project we're undertaking now with Champlain LHIN, hopefully with eHealth Ontario funding, and we'll know in a few months about that. But really looking to capture those paper-based things, so things like discharge summary, emergency department face sheets or fly sheets, information from visits to the hospital for surgery or for clinic visits. So things that's now passed around generally in paper and doesn't fit into the eHealth Ontario repositories that they're going to create at a provincial level. And then lastly, point of service systems. So Doug spoke to this as well. A lot of data lives within EMRs in physicians' offices, CMSs in the community, and HISs, hospital information systems. We're not going to suck all that data out and present it in any of these repositories. It's not really appropriate, but that will be a key data source as we move forward with integration. The next level on top of that then becomes this integration layer. So from an agency's point of view, the hospital community agencies need to maintain your own local system built to standards, and then have a way that we can integrate that across all the systems. So things that would be in here, that Doug mentioned, data checking, how do we make sure we've got the right patient, the right user? How do we transfer data? So do we move it from the hospital system into an EMR? Do we move it into a repository? Do we call it up on demand? Those are things that the integration layer will deal with, along with our privacy and security standards. How do we present that data? So an example we have received recently, as we've been working on reducing ER wait times, is a physician asked, it would be really nice if I just knew what community support this person had when they went home. So finally the lights have gone on that actually the community had benefit. And we don't have a way to present that right now, but through some type of a common assessment, we might be able to pull that information up so that the doctor can say, I know what services this person receives, I can feel comfortable that they can go home, and I can notify those people that there might be some extra care required or some change to their care plan. And then lastly, referring patient information. So Doug mentioned the value in this, and the one that we're working on right now with Cancer Care Ontario and eHealth is how do we transfer people from hospitals to long-term care to reduce time and effort around ALC patients. And then portals, which everyone seems to have their own opinion on what they are, but I think Doug did a good job of covering that off. Really bring together selected data from multiple sources, so not all data, not all needed, presented in a manner that supports the needs of the user. The information that a physician needs to make a decision in the ER is different than what a practitioner would need in the community. And the time frame is different in terms of how long you have with the patient, and the decisions you make would be different. And then how do we link those portals to other systems? So As an example, if you're working at Kingston General Hospital, you may not know you're using a portal. It might be built in directly to the hospital information system, and just behind the scenes pull that information up. But it builds on all that, checking to make sure it's the right user, it's the right patient, and it presents it in a way that's clinically appropriate. And then standards. I think I did a good job of discussing this, but really what the data definitions are. How do we take a standard approach to refining the process? Sherry spoke to the fact that we need to redesign processes, not just automate bad process. So we need to look at taking standard approaches to that so that we have common tools. You'll hear a presentation from Renee later around the lean methodology that was used at Brockville, and which a number of industries have used for a while and healthcare is starting to come into. And then lastly, a standard way for collecting information to support managing the system. So again, you'll see some of the presentation around the SMILE program and using the assessment not only as a way to manage clinical care, but also to determine if we're managing the system correctly. So I've gone through that. Hopefully, you can see this picture a bit bigger than Doug, but kind of chunks it out and say, we're going to be working on locally developing the standards. So Julie's going to speak about some of our projects we have around implementation and adoption to start building that foundation. We're going to start looking at the data layer. So the province is looking at the shared repositories. We're working on the common assessment pieces with the CCIM group. The shared clinical repositories are going in place through regional repositories like Images, OLIS, and drugs, as Doug spoke to. Our clinical document repository, so the item in purpley color there, is one that we're looking for funding from eHealth Ontario and hoping to cooperate with Champlain to move forward in a joint LIN. And then the yellow box really is those systems that everyone manages and runs. So working with all of the agencies to help to bring those systems up to a level where they can have standard information available, share that standard information, and access other information. And then building on top of that, the integration level, the e-referral level, and eventually portals. At this point, we're waiting to see where the province goes with portals, what other LINs do. eHealth Ontario is very much encouraging LINs to work together, so we have spoken to Champlain about how we could share their portal so we don't incur the full cost of development. And as we implement further projects with them, we'll look at that. Initially, though, the yellow box is where it's available, having the point-of-service applications be able to share information and access things through that integration layer. So through the clinical data repository, we'll work with the primary care and some of the EMR vendors to see how we can share that information seamlessly. So we started with our strategy and gone through it, and people always ask, well, what are you really going to do? This is kind of what the architecture looks like. But in terms of what it's going to do, I'm just going to walk through a couple of different scenarios. And I am not a clinician, I'm an engineer. I'm a chemical engineer, so I know a lot about drugs and alcohol, and that's about all I remember. But I'm going to walk through a couple of pretty basic clinical presentations and go through a 1, 3, and 5-year time frame. Now, don't hold me to the 1, 3, and 5 years. We all know that those will change a bit. I used to work with someone, and I'd ask him, when are we going to do something? He'd never say, December. He'd always say, well, when the snow flies, we'll talk about it. Or when the leaves start to turn. So I didn't really appreciate that because I was young and quite enthusiastic. But as I've grown older and mellowed, I have more appreciation for it. So we could look at these in terms of elephant gestation times. So if we look at a patient arrives at the ER, what information systems are available. Right now, generally the physician can access the local hospital system and some provincial data, largely the Drug Profile Bureau, which gives, for patients receiving Ontario drug benefits, gives them a list of when the last dispensing, if that's the right term, was made. Not necessarily whether you took it or not necessarily what the order was, but when a drugstore actually gave you the drugs. So there's some clinical value to that, but not a lot of information beyond the local hospital. In a year, we believe we'll be able to look at providing information on CCAC services and e-referrals. So there's a project going on provincially where we show up at the Emerge department. It will check and see if you're on the CCAC roster. If you are, it will inform the physician of that. It will also take up to the case manager at the CCAC and start to proactively say, well, maybe this patient should be based on a standard number of questions that are asked within the Emerge department. So starting to link in the community through the CCAC, access to x-rays from other sites. So right now we are filmless within the region, but we're not sharing those images. Through our development of the diagnostic imaging repository, we will be. And we believe access to some information from other hospitals. So part of the clinical document repository will allow us to build in things like seeing discharge summaries or emergency face sheets. So you may be able to see what's available.